thank you so much for inviting me to speak. It's really quite an honor to speak for this organization, whose interests are after my own heart. In the daily job, I'm a clinical oncologist at Highland Hospital in Oakland, which is a safety net hospital that cares for underserved patients who often present with very advanced stages of cancer. And I think a lot of that is due to lack of access to proper medical care and proper screening, and decrease in health literacy, which is hard to overcome. But we see, compared to my time at academic centers and private practice, we see a lot of advanced presentations of malignancies. And once in a while, we see a person with a very curable cancer who presents so late that we can't cure them. And that sort of things happens throughout the world, and parts of America and rural parts of America. So I'm going to start with a little bit of prevention and then talk a little bit about some of the dilemmas with screening, to give an overview. Part of my training that's relevant for this, I don't want to go through my bio per se, but I did a fellowship at the National Cancer Institute in medical oncology, which is learning how to treat cancer and how to design clinical trials. And a separate fellowship was in cancer prevention and control. So a lot of my thoughts regarding that come from the training I had there. There's a special branch there called the Division of Cancer Prevention and Control. So when we talk about prevention of cancer, we talk about primary prevention, which are things that we can do to our behavior to decrease cancer risk on the individual level, or that can be done on the societal level, which is where public health comes into play. And secondary prevention, we usually refer to as screening. That term secondary prevention is not widely used, but screening for cancers, again, at an individual level or population-wide with national programs or international programs for cancer screening, is referred to as secondary prevention. And the high-tech stuff is very interesting and the way of the future for screening and secondary prevention. Primary prevention is very low-tech and not a lot of change from year to year, but it is fairly effective. So I wanted to go through that to start with. These are things that we can do as individuals, and we can also work on doing as societies and getting organizations and NGOs and governments to involve to eradicate some of the sources of cancer. The first thing we can do that we hear every day is what we choose about our diet and nutrition. Michael Pollan, who's written some books and is a big speaker, summarizes as that eat food, not too much, and mostly plants. So we think there's very good data that those of us who can work towards having a vegetarian diet or as close to it as possible have a markedly decreased risk of developing cancer, particularly for cancers of the GI tract, where what we eat has direct exposure to the epithelium and we know can increase the risk of cancer. The things to try and avoid are processed food, highly processed foods, saturated fats, red meats, and grilled red meats, which have their own set of carcinogens, as well as eating too much on any given day. There's a good data that you can try and remember that Japanese people, when they were in Japan in the 20th century, had very low incidences of breast cancer, colon cancer, and prostate cancer. But when they started moving to America and adopted the regular American diet, those cancer incidences went way up. So it's not genetics in that situation, it's clearly environment and what we eat. Another diet that's also talked about a lot is the Mediterranean diet. There's some great books on that, one by Walter Willett and some other ones. The Mediterranean diet is fresh fruits and vegetables, non-processed foods, low saturated foods. There's a lifestyle there with communal eating and very little dessert and very little red meat. And part of the Mediterranean diet that has become a little bit more controversial is drinking red wine with meals. So I don't know if everybody looked today, but Morgan Spurlock passed away, and there were some articles about him in the newspapers. He was famous for doing a movie called Super Size Me, where he ate nothing but double portions of McDonald's for a month and watched his health deteriorate. And he died very young at 53 of cancer. It's not stated what time, but as I read some more about him, he was also an alcoholic. And we know that alcohol is related to cancer. I like to think my interpretation of the literature is correct, which is that modest alcohol use does not really increase your incidence of cancer, because typically the cancers I've seen due to alcohol are from chronic exposure and high doses. For example, alcohol that causes chronic pancreatitis can lead to pancreatic cancer. And patients who have esophageal cancer from alcohol or head and neck cancer typically have a high amount of alcohol per day. So that's a tougher decision. But wine doesn't seem to protect from cancer, which is what was fashionable to think about for about 10 or 20 years. So number one is diet nutrition. Number two is tobacco. Do not smoke, vape, or use tobacco. If you do quit, the carcinogens in tobacco are products that are exposed directly to the epithelium of the lung, the mouth, the esophagus, and quitting smoking will markedly decrease your risk of getting cancer. In fact, the data shows that if you quit smoking completely within 10 years, your risk of getting lung cancer is pretty much the same as if you never smoked. And we have some worldwide issues with smoking. In America, there was greater knowledge about smoking and cancer starting in 1965, and the tobacco companies saw that smoking rates were dropping in America, and so they went to the third world, where smoking is also a big cause of cancer. It's clear that exercise is very healthy for you. You don't need to become a marathon runner. 30 minutes of aerobic exercise 3 times a week or more gets you on the path towards better health, decreased risk of cancer, and decreased risk of cardiovascular disease. And the nice thing about number 1, 2, and 3, primary prevention, not only decreases your risk of getting cancer, but it will also decrease your risk of getting coronary artery disease and stroke. So you get a lot of benefits from changing your lifestyle. I'm not sure that stress is a causative agent for cancer, and we tried to think that it was for heart disease, but certainly if you can temper your reactions to life's stress, you'll have a better sense of well-being. Avoiding obesity, so independent of your diet, obesity turns out to be an independent risk factor for a lot of bowel cancers. So trying to get your body mass index below 30 or below the appropriate for your body type is a noble endeavor. That seems to be mostly related to diet rather than exercise, but both are very important. Use sunblock and a hat when outside. We see melanoma, and I think the data is best that melanoma is related to not the total amount of sun exposure, but to periodic sunburns. And there's a big melanoma belt in Australia where melanoma incidence is very high. Get vaccinated. These two viruses, hepatitis B and human papillomavirus, are responsible for a lot of cancers worldwide, and it would be a very simple thing to vaccinate people worldwide and eradicate these malignancies, except access to vaccines is not uniform across the world. I think in America, most children are offered hepatitis B and HPV vaccine, and hepatitis B is linked very strongly to hepatocellular carcinoma. Human papillomavirus is linked very strongly to 5 malignancies, including cervical cancer, anal cancer, and oropharyngeal cancer, all of which are on the rise in America. So these would be very easy cancers to eradicate. It's not a intellectual or biologic problem anymore. It's a public health problem about getting people vaccinated. And the last one is to avoid environmental toxins. Certain cities have very high levels of pollution. Beijing has now a very high level of pollution and an increase in many cancers there. It's not always possible to pick where you live, but avoiding air pollution and industrial toxins can help. There turns out to be more toxins being discovered and worked on that are turning in the air, water, and food. A lot of occupational exposures. Benzene is known to cause AML for more than 100 years now. Roundup has been linked to non-Hodgkin's lymphoma, and you may have seen some of the lawsuits on that. Other pesticides and herbicides are linked to hematopoietic malignancies. Chronobiology is a very interesting topic. I finished a book by Russell Foster recently about chronobiology and how we match up our life, our day-to-day life, with the regular sun rise and fall can have an increased incidence on a lot of diseases. So there's a relationship between people who work at night with neon lights who have a higher incidence of cancers. And then we're reading more and more about PFAS and forever chemicals and their relation to adverse health events. This last point, be lucky, and this quote from Ray Charles, there are a lot of cancers, I think, that just occur in people who are thin and otherwise healthy. And some cancers, I think, are just a result of bad luck or things that we don't understand that cause them. I can think of young patients with devastating brain tumors, glioblastoma multiforme, as most of the time being quite unlucky. So we want to focus on that as much as possible. Not something we can change, and it's sort of a trite saying, but luck does play a role in who gets cancer and who doesn't, which is why we think a lot about secondary prevention and screening for cancers or early diagnosis of symptoms. There was a lot of research, and there's still some research on chemoprevention, which is things you can take to decrease your risk of cancer. And there are some FDA-approved indications for tamoxifen and raloxifene for decreasing the risk of breast cancer for patients who have a very high risk of getting breast cancer. That can be done. Aspirin can prevent colon cancer in patients who have a genetic syndrome called HNPCC. These are not widely used in the population, but for certain patients, this may be very effective, and I think research continues in this area. Screening for cancer is the idea of picking up a cancer at a very early and treatable stage, such that your overall life survival is back to the same as if it was before. And these are the 5 cancers that we screen for, mostly in the US, where we've got evidence-based regarding screening, although as I'll talk about, screening depends very much on your pretest probability of having that underlying cancer. So we have breast cancer screening, mammography, the age of which has now been lowered to 40 in the last set of iterations. We have ultrasound and MRI. Biologically, for younger women, it's harder to pick up a breast cancer on mammography. So for screening for younger patients, sometimes we rely on MRI, particularly for patients who have a BRCA mutation who are in a screening program. For colorectal cancer, I think this is the test that has the best data about screening and survival. You can do fecal occult blood test. You can do a blood test that looks at certain mutations called Cologuard that you'll see on TV, and you can do colonoscopy. The ages for these have been lowered recently to age 45, and some would say 40 in African Americans. And screening programs are usually accessible to people who are insured and have health literacy. The test there can not only pick up a cancer early, but can remove a precancerous polyp, preventing you from getting a cancer. Cervical cancer, unfortunately, cervical cancer and endometrial cancer in the United States are increasing in mortality for reasons that are not totally clear, but cervical cancer is detectable at early stages because of its long natural history with Pap smear, and now I think we're moving more to HPV testing, recognizing the nearly ubiquitous role of HPV in cervical cancer. So patients who have access to medical care should be screened for cervical cancer appropriately and diagnosed at a very early curable stage. Prostate cancer is definitely screened for in the United States with a test called PSA. I'll talk a little bit more about that. And then more recently, the last one that we've added is lung cancer for patients who are at high risk for lung cancer, which would be those who are still smoking or have quit smoking for less than 10 years, who have 30-pack years or more. And the screening there is low-dose CT followed by additional studies if a nodule is detected. Now we're doing tremendous work in cancer-causing genes and figuring out who might be at a higher risk for cancer due to germline mutations or hereditary predispositions. Some of these I mentioned here, BRCA1 and 2, HNPCC, and most centers, particularly academic centers, have aggressive screening programs to detect these cancers early in a very enriched population. And there's a whole field called genetic counseling, where patients can be counseled regarding their probabilities and family history. So we're always on the lookout now in clinical oncology for familial clusters or familial cancer syndromes that we can not only help the patient with, because some of these are now targetable, these genes, but also their family and warn them and get them in screening programs. The problem with understanding screening, which is a fairly ubiquitous problem among physicians, is understanding some biostatistics. So there are 4 main terms that we talk about. One is the ability to detect something in people who do have a disease, which is called sensitivity, and specificity, which is the ability of a test to say that patients do not have disease. And the positive predictive value and negative predictive value, the positive predictive value means that a person with a positive test has the disease, and negative predictive value means that a person with a negative test does not have the disease. And at the first level, I think people, including physicians, think that if you have a test and the test is positive, that means the person has the disease. So these concepts are usually taught at some point, but they're very hard to understand. I think for many people, that the accuracy of a test depends on the underlying pretest probability of that. So these are grids that we'll draw on the board when we're teaching interns or residents about tests for sensitivity and specificity, meaning if you have a negative test, you don't have that disease, which is very important in a screening test, because a screening test is usually followed by an invasive test to confirm the diagnosis. Positive predictive value and negative predictive value. So I think a lot of the audience is probably involved in artificial intelligence and neural networks, and so are familiar with the concept of Bayesian analysis, which is not a common concept taught to medical students and residents, but we use Bayesian analysis day to day as clinical doctors, and so it is very important to understand it. But the pretest probability of having an underlying disease, in this case cancer, influences how accurate the diagnostic test is. If the pretest probability is very high, the test becomes more accurate. If it's very low, the test becomes less accurate and has a lower predictive value. So these are two new directions in screening that we'll hear more about that get in the newspaper very often because the technology is very interesting. It's technology that built upon the revolution of molecular biology that really happened in the 1970s. And there's a lot of enthusiasm for detecting cancer early, obviously. So I'll touch on a little bit of radiologic screening and then blood-based tests that are making the news today. So this is from April 15th. Private equity-backed firm launches with an AI startup to launch nationwide whole-body MRI offerings. And at first value, this seems like a very good thing. You can have an MRI and pick up a cancer early. MRI doesn't have radiation that works in different ways, so you're not going to cause cancer by doing it. But there are problems with widespread screening for cancer. Some common harms to think about. These concepts are also very sort of hard for physicians to understand, but a lead time bias means you pick up a diagnosis of cancer early, but you don't have any improvement in mortality. So all you've done there is sort of make the patient nervous and anxious, but you're not actually lengthening their lives. And then length time bias is cancers that are slowly progressive, where detecting them might not make a difference in the patient's outcome. It's a good model to think of that was adapted by Gil Welch about different animals in cancer and how screening might affect them. So the red animal, the bird, these are cancers that grow so quickly that screening won't detect them in time. And for patients who are getting regular screening, such as mammography every year, every other year, when these cancers show up, they tend to be very aggressive, and they're called interval cancers. And it's not because the screening test necessarily failed. It didn't. It's just because the cancer is growing so quickly that it happened between the two screening tests. And then the rabbit is sort of our goal in screening, something that grows slowly enough that when we pick it up, we'll have a difference in the outcome through our screening test. So we want to make every sort of cancer screening test as close to picking up rabbits and not picking up turtles or snails as possible. But the turtles and the snails are cancers that are growing very slowly or not growing at all. And in fact, cancer growth it follows nonlinear dynamics, and it's likely that cancers can go away in your body that may have been picked up on a screening test or that may never grow at all. So when you pick up those cancers in a screening test, it's called overdiagnosis. These are cancers that are overdiagnosed and that are a big subject of debate and literature. One is low-grade prostate cancer, because we do a lot of PSA screening. And so we've adopted a different stance for these low-grade prostate cancers, which is called active surveillance, where the patients will be monitored and only treated if the cancer sort of grows. So we get a better natural history of those cancers. Ductal carcinoma in situ of the breast, there's a lot of this detected with the use of mammography, and we're not really improving the cure rate of these patients at all. Definitely we're overdiagnosing. So we're looking for ways to de-escalate these. In breast cancer, some of the breast cancers are actually snails or turtles and are overdiagnosed. Papillary thyroid cancer and then melanoma too can be overdiagnosed. So this was a striking example from South Korea, where they decided to start doing ultrasounds on large portions of their population to detect thyroid cancer early. And this is a classic sort of graph for overdiagnosis. They started screening, and the blue line shows that the incidence of cases dramatically increased. The mortality did not change at all. So these are overdiagnosed cases. And the downside of this are personal anxiety for the patients who think that they now have a terrible cancer, as well as the treatment. In the case of thyroid cancer, they usually undergo surgery, they may undergo radiation, they may need to be put on thyroid medicine for the rest of their life. So we are seeing a lot of thyroid cancers in America with, for example, PET scans. We pick up these thyroid nodules that we wouldn't have felt before. So the incidence of thyroid cancer is also going up in the United States, and it's not clear we're affecting the mortality. And I should say this is the most common subtype of thyroid cancer, called papillary thyroid cancer here. This is another look at it in South Korea, and you can see on the right that the percent of adults who were screened went from 10% to 25% with no benefit from that for individual patients or for the country at large. Screening tests should be highly sensitive and specific to detect asymptomatic and early disease. Again, patients with a high prevalence are going to have a higher positive predictive value. The test itself should be relatively safe and cost-effective. One of the issues with the screening MRIs that some physicians will worry about is that the MRI is paid for out of pocket, but then when something abnormal is found in the MRI, it's the regular health system that pays for all the biopsies and testing that follows that. And if you think about it, California, more than half of the people are on public insurance, either Medicaid or Medicare. And the rest of the insurances in America, it's not a free ride because we all pay for those insurance costs out of our salaries at work. And those premiums have been going up by 15% every year. So we might think that MRI screening makes sense at first, but it is a very expensive downstream testing cascade. And then we want to have screening for disease where early identification and treatment have been shown to improve clinical outcomes. We don't want to screen for something that we don't have any good treatment for. The remainder of this talk is extremely controversial, and these are graphs that come from England, and many oncologists and breast surgeons actually believe this, but are not willing to say it in public. But it's thought that screening for breast cancer may save a small percentage of lives at the counter side of having a large percent of patients who are overdiagnosed with breast cancer. So there's the problem with the anxiety of having a cancer that may never have harmed you, as well as all the biopsies and procedures that went there. And again, this will be better in an enriched population with a higher pretest probability, but we feel that breast cancer screening with mammography has overdiagnosis, particularly if you do it in women between 40 and 50, where the sensitivity and specificity will fall. This may be outdated that prostate cancer does not save any lives, according to this graph. There's certainly a lot of men who are overdiagnosed, but what happened is the U.S. Preventive Task Force for a while said no to PSA screening, and then as a result of that, we saw a lot more men with metastatic prostate cancer. So I think the needle has probably swung back on PSA screening. It does have a lot of harms with it, with overdiagnosis, but I think that the data is a little bit better about PSA having a role. Although the gentleman who developed the PSA test did not think that it should ever be used as a screening test. And now with these patients with low-grade prostate cancer, we can put them on active surveillance and perhaps spare them from treatment that's not needed. So these are the harms with screening tests that are false positives: incorrect labeling, which can be psychologically difficult for patients, inconvenience, expense, physical harm in some of the follow-up tests, and imaging can pick up what's called an incidentalloma, which is an abnormality that doesn't actually correspond to a disease. This is called the screening cascade. Persons who are screened can ultimately end up in the lower left corner of this with benefit, where they have earlier treatment that works better. But there's a lot of false positives, indeterminate findings, incidental findings that can get you to the right side with no benefit. And so the thing here that we hope for from technology, from genomics and proteomics and AI, is to shift the balance of screening so that we end up in the lower left-hand corner much more often than we do in the lower right-hand corner. There's a great article that I read every couple months by the brilliant writer Siddhartha Mukherjee from the Wall Street Journal on December 17, 2021, that talks about some of these issues with screening with ctDNA and screening with imaging, titled "Will We All Soon Live in Cancerland?" And it gives a very balanced sort of opinion about how these patients will deal with the fact that they've been diagnosed with cancer that may not actually harm them. And so I would urge anybody really interested in the topic to just pull that up on the internet and read it then. So in summary, primary prevention of cancer is always worthwhile. It may prevent cancer for you. It may also prevent you from having heart attacks, strokes, other diseases, type 2 diabetes, both at an individual level and a population level, certainly in other countries besides the US as well. Being healthy is associated with a better sense of well-being and a higher quality of life. Screening or secondary prevention has well-documented benefit from screening tests, and I talked about the 5 most commonly done ones here. The pretest probability affects the accuracy of any screening test, and the potential harms are overdiagnosis, unnecessary testing, and worry. And I believe that over time we'll continue to improve our ratio of benefit for screening for cancer. We're still working out the biology. Every month new things come out and newer technologies are evolving. So thank you very much for your...
Kevin, if I may, request you your last word and your crystal ball as to where this field is moving, and is there a hope, to what we say from, catastrophe to a manageable disease, and over what period of time?
I do have some fears that this technology will be utilized before it's perfected. I mean, I have friends who've already done cancer screening tests and whole body imaging, who are otherwise healthy and are making sure that they don't have cancer. But I think that over time, the precision of precision oncology and precision screening tests will continue to improve to the point where it becomes very useful. I also think that we'll have to understand more about the dynamics of cancer growth, in that if we pick up malignant clones earlier and earlier, do we have a way to differentiate them back to normal tissue without actually doing surgical excision or things like that? And monitoring, I think, will be dramatically improved.